New research says flex spine position is the best position for squatting. And then if you really look deeper, you're like, or does it say that? So we're going to dive into that today. And we are the two research geeks, Dr. Evan Osar and Dr. Darren Smith. I love that little Bitmoji I found for you, Darren, because it actually does look like you. We just need to get you some glasses. So for the next time, we just need to get you some glasses. But I thought it kind of looked like you. So
yeah. Oh, yeah. Totally. That was good. That made me laugh a little bit when I saw that. I do have some glasses. I'll be sure to wear them next time. I'll throw them out.
Right on. All right. The study we're going to discuss today is by Holder, Sullivan, and Bucock. Oh, I never noticed a Bucock. Wow, that's an interesting name. Flex spine, lumbar spine postures are associated with greater strength and efficiency than lordotic postures during a maximal lift in pain-free individuals. This just came out this year in Gait and Posture. So you want to start us out with the type of study that this is, Darren?
Yeah. So it's really important when you're looking at research. It's what most people will do is we will all start the title will grab our attention, and then we'll dive right into the abstract because it's nice, it's convenient. It gives us a breakdown and just a blow by blow of, okay, so here's overall summary of what you're going to be reading and looking at here. So it's important to know what type of study was actually performed, because the way that information is being, the methodology of that study is going to, or the way that the study is actually put together is going to determine how that information can actually be utilized with your clients. So for example, this is a randomized control trial where they take individuals and they randomly have them go through some different patterns to see what happens with torque and muscle activation. But when you're looking at a randomized control trial, it's great. It's considered very high level evidence because there are a lot of controls. The goal of a randomized control trial is to take and control the environment as best as possible. Now, we can't control everything. Every study is going to have its limitations, and we have to accept that, and we have to make sure that we're talking about those things so we understand them and we can make future research better. But when we take and we control an environment and we're randomly assigning individuals to different groups or different interventions, that is different than how we actually work with individuals in an actual environment, in whether it be a gym, whether it be a rehabilitative setting, whether it be a telehealth setting. So if you're the goal, bottom line of a randomized control trial is to take and try to find out some information that we can generalize and get to work for the greatest amount of individuals as possible. Now, it's not going to work for all individuals. So you guys all know that are on the line here that individuals all respond differently. And day to day, hour to hour, between set to set, it all changes. So you just have to realize that if you're ever reading something and you're consuming some research here, if you see that something is randomized, they're trying to generalize the information so that we can help as many people as we can when we're using it. But that doesn't mean it's going to work for everyone.
And that's interesting because when you look at who was studied in this particular study, it's very important to point out who was actually part of this study. So you want to talk about that a little bit?
Yeah. So we had a total of 13 healthy is the key word there. That we have bolded and underlined, healthy males and females. It's important to make sure that when we're trying to generalize information in a study, that we get the best representation of the population that we can. So we're not, if we want to look at a particular sport or a particular group of people, we have to make sure that we're representing that. And in this case, they're trying to represent males and females that don't have a history of any pain. These people are healthy. There's no complaints. And additionally, they don't have any general medical conditions that could potentially cause pain, such as like an osteopenia or maybe some arthritis, or any kind of musculoskeletal injuries. We want to make sure, we want to know how this intervention is just going to affect normal, healthy people.
Absolutely. And again, it's important to realize that I forget the actual age of these individuals, but they were on the younger side, like more like the 20-year-olds. So as you and I, many of us are working with the 50, 60, 70, 80-year-old population, this information may not be 100% applicable to that population. So we want to make sure that we're looking at who did they study and what was their history going into these randomized, quote unquote, randomized clinical studies, because it wasn't so randomized when you look at the population, right? It was pretty homogenous population. Actually, can we say that almost like it was a pretty homogenous sort of population?
Absolutely, and that's the goal of a randomized control trial, because you want to take, when you're putting a study together, you have some kind of a study question, and that study question is going to address a particular population. So for example, there's a lot of fall prevention studies, but that's going to be on more elderly, late middle-aged individuals, right? And they're going to have certain conditions that go along with that. I can't necessarily take that information and directly apply it to the athletes that I work with. But sometimes one of the limitations that you're going to run into, Evan, is that may be all the research that's there. So we don't have anything else to go off of. So that's important for you guys when you're looking up research or having a conversation with research about a particular topic such as this, is that you want to say, okay, who was studied in this? Because if that's not the population you work with, it doesn't mean that the results that they saw in the study are necessarily going to be the same for those that are in your setting.
Absolutely.
Okay, so what do we actually measure here? So it's important to understand when reading any study what's being measured and how what that measure can actually tell us. So that's what validity is. Does something measure what it actually says it's measuring? So there's a lot of times, like maybe a study will say that they're using a survey to get at what they want. Other studies will actually use physical data to get what they wanted. Other studies will actually utilize a combination of both those things. So we want to make sure that what we are measuring and what we are stating in terms of how things will work kind of line up. So a good example of that, Dr. Osar, would be is if we're taking someone and we are measuring strength, okay, well, we know strength can change based off of, is my strength going to be the same in a supine, I'm laying on my back position, versus a seated position versus a standing position? So if you're taking measurements in those positions, you can't assume that they're going to transfer over to all those other positions. So that's what we mean by valid and repeatable. Lastly, we also want to make sure that the measures that are being used, there's a lot of measurements that are field-based versus laboratory. So the laboratory measurements are good because they use the big fancy equipment, and they can give us some really good information on things that we can't see with our eyes and get in terms of feedback from our patients when we're working with them. So it's kind of like the quote unquote microscope for us, right? It can really help us. So we want to complement those things. We want to put them together, but we want to also understand, okay, how can I take these lab-based measurements and how do I use them in my field-based setting? What can I do? Because I don't have this fancy equipment. What's my take home, and how will this information help me and those I better serve? So in this particular study, they looked at low back and knee torque. So when we're talking torque, we're talking rotational force, okay? And then they're also looking at neuromuscular activity. So we're looking at the source of the muscle recruitment, the power source. So we know that the nervous system controls everything. So how well does it actually control the torque that is being produced here? Okay, so what did these guys actually perform, and what was looked at? So what they did a number of things here. We're going to talk specifically where they found their differences between things. So they looked at a lot of things, but we're going to get right to the heart of the matter. And we're not going to look at the stuff today to where they really didn't find any clinical findings, if you will. So what they did was they took individuals, they put them in a knee flex position at about 45 degrees. Okay, like we're seeing in that picture, they're probably a little bit more than 45 in that picture, but close to that. And they asked the individual to perform a 2-second increment in which they were ramping up into a particular contraction, and they would go into a 3-second hold of that isometric force. So they would have an actual contraption that was set up to where they had force plates so they could feel the force going through the feet, as well as they could lock them into position while they're pulling up or going down as hard as they can isometrically. So the postures that were utilized here was they looked at the individual in a fully flexed standing position. Then they looked at the individual in terms of the lumbar posture, if we take and maximally extend that person. So we start to arch that low back like we see in that first picture on the left there. And then we had a midway between maximum flexion and extension. So these individuals were not given any instruction on form. They just put the individuals in these positions, and the individuals utilized and performed the movements that they were asked based off of the movement patterns that they currently use and their body views as efficient. Okay, so real quickly, what is the study talks about neuromuscular efficiency, and this is really important. You have there's several different definitions of this, but the easiest one here is to think about muscular recruitment. So let's put it in terms of like a high-powered flashlight. Okay, so someone that has a high neuromuscular efficiency, they can tap into their power really quickly, right? They're going to take and be able to do the movement with a lot of power. It's like having a super-powered flashlight that's really bright, but the drawback to that is it draws a lot of power and it drains the battery more quickly. And I think we'd all agree with that. We all have a good understanding that the more power we use on an exercise, the more torque we create, the faster we're going to fatigue out. Okay. On the other end of that spectrum, an individual that has lower neuromuscular efficiency, they're going to have a less bright light, but they can keep that light on for a longer amount of time. Another example we could use here briefly that could add into torque as well too would be, think about a cordless drill or flashlight. Okay, when you have that guy completely charged up, it's got all its torque, it's got all its power. But if I'm going and I'm asking that drill to do a lot of high-powered work, it's going to drain the battery really, really quick. And what happens when you drain that battery? The torque on the drill actually decreases. Okay, so that's what we're seeing here. So we're looking at torque in terms of contraction and power output, and then we're looking at the neuromuscular efficiency. Is that battery? How long does it stay on, and how quickly do we drain it?
And again, I think that's a huge point, Darren, and great analogy. I love those analogies. Is because when we're talking about our clients, for example, in squat, when we looked at the squat research data and then what they actually looked at, how they studied it, it was basically 5 seconds worth of work. And what we want to think about now is taking that to, starting to just think about how it applies to our clients. That was 5 seconds of work. Rarely do we ever have our clients do. Now, again, if you're training power, run or a 1 rep max, 1 RPM, for example, maybe you're doing 5 seconds of work, but probably not. When we're working with our older clients, for example, they're doing sets that last more like 30 to 45 seconds to a minute. So again, is the information from the study 100% applicable to how you're then training your clients? So I think that analogy you just gave of the cordless flashlight and or drill is a really excellent analogy to start to think about that neuromuscular efficiency and how it applies to this particular study.
That you make a really good point there, that I'd like to just kind of build off of, and that is one other thing that can drain that battery that we know from research is the time that we spend underneath tension. So time under tension, how much tension we actually have with our contraction, because that can improve our motor control, but dependent on how well the person adjusts to that, we all know that people can only spend a certain amount of focused time under contraction based off of the environment, whether you're using weight, whether you're using non-weight, whether you're putting them in a weight-bearing or non-weight-bearing position. Their body has different strategies with handling this stuff. So the neuromuscular efficiency is going to change based off of what you're asking them. So if we're asking them to do 5 seconds worth of work, the battery and the central nervous system, it's being given a different task. It's not the same as doing 2 seconds of work, or if we want somebody to hold something for 30 seconds. Okay, so we have to understand that the positions aren't all equal, and we're providing different demand, which is going to lead to different output. Okay, so what was discovered? And here's where people kind of get scared. When most people read research, they skip the statistics section. And this is one section that I would like to be able to educate everyone on. This is a big love of mine. Nobody goes into a master's degree program. This is why I teach the course, saying I love statistics and I can't wait to take this class. But my job is to help people utilize statistics to make better informed clinical decisions, not to sit down and do a lot of math. We have programs that take care of all of the math for you. So it's really understanding the statistics. So what you will see in a lot of research studies is they have this thing called the p-value. Okay, and this p-value tells you if you have statistical significance. What is statistical significance? That just tells us the things that we're comparing and we're looking at, they're different. They are mathematically different. That's all. The question clinically that we have to ask ourselves, if we're looking at these different positions and torque output and neuromuscular efficiency output, what does that difference mean clinically? And a p-value cannot tell you that. So that's the take-home point for everybody here online right now. It's good to know that there's a difference. That's the first step in learning that, hey, we're onto something here. So we don't negate it. It's important. But you can't look at that and say, we got a p-value of 0.003. So holy cow, that must mean that this is super important. Nope, it does not. The lower the p-value is, the more different things are. Okay. But that still doesn't, clinically, that can't tell us anything. So what they found here in this study is that when they compared the flex to the mid-range posture, there was a difference there. When they looked at the mid-range to the fully extended posture, we got a difference there. And same with the flex and extended posture. So all the postures were different from each other when they were compared in terms of the torque that took place and the pelvic position that they were actually put in. In addition to that, so we see that we got torque changes across all 3 pelvic positions. Okay, we also saw that neuromuscular activity, or that output, the battery output from that flashlight or cordless drill, we have differences between moving from extension into mid-range and then moving from that mid-range into the full flexion. So all we know from reading this is we got differences going on. That's it. So the next step you got to ask yourself is, okay, they're saying we have statistical significance and we got differences. You guys have to say, how big are those differences? Okay, so if I'm reading a study, here's a perfect example. If I'm reading a study on like range of motion and the difference that they get from doing a certain type of movement patterning or stretching is 2 to 3 degrees, does that mean a lot to you personally as a clinician or somebody who works with these people? You may say no, 3. I know other ways in which I can get 10, 15, 20 degrees. So that's a perfect example of we can have a difference, but that difference can be so small that it doesn't mean anything. So buyer beware, basically, right here. Recognize it, look for it, but just understand that's all it's going to tell you, and that is it. Super,
Awesome.
super important.
And as you were mentioning, like the smaller the p value, the bigger the difference.
Potentially, yeah. And again, that looking at these numbers here, like you see one, really what the p-value will represent is possible amount of error that we could be making a mistake and saying that there is a difference. So if we look at this, obviously, if I want to make a comparison there, if we look at the mid-range and the extended posture, there's a possibility that we could be making more of an error there between mid-range and extended versus flexed and extended because the number is much lower. That's it.
Got it. Awesome.
Okay, so applying the information. This is the fun part. This is what you guys are on here for. What are we going to use this stuff? Number one, this was all done isometrically. So this was a controlled environment, and the people that were looked at were in a certain population. Okay, so first of all, you got to ask yourself, do I train people that are in this age range, that are healthy, and am I doing isometric work with them? And maybe you are, and maybe you aren't. That's the first thing. So if you are, cool. This information will mean a little bit more for you. Checking the box there, right? Next, what we learned here from the EMG and the torque output was that lengthening these erector spinae complexes and the multifidi, the lower, the deep musculature of the back, using pelvic prepositioning, produce greater torques across all the different movements. Okay, and we got greater neuromuscular activation. The light was shining brighter out of the flashlight, or the drill had more power. One of those two. Okay, now what we don't know is all they looked at were 3 muscle groups. We looked at some obliques. We looked at the erector spinae, or those paraspinal muscles on the back. And then we also looked at some of the deeper extensors. We know that squatting is much more than those things. Okay. I'm willing to bet that none of you use the squat and say to yourself, I'm only doing this squat to help somebody activate their extensors in the spine. I highly, highly doubt that. So that's what this study is telling us, that if we take somebody and we put them, the more pre-positioned that we flex or we anteriorly tilt that pelvis, the greater torque we're going to have. So the more rotational force we're putting on the system, and then the greater activation we have to have. That light has to shine brighter to control that force. That's all that means. Okay, so that's the take home there. So you got to ask yourself, well, wait a minute, we got stuff going on at the ankles, the knees, the hips, the whole spine. What about that whole cylinder that helps keep us upright? So there's more going on that overall impact in motor control and movement patterning. They're not looking at movement patterning here. They're looking at individual muscles and what happens to those muscles when we put you into a particular position. That's it. And we're not looking at, okay, so if we're going to work out and we're going to put somebody in more of a lumbar, rounded lumbar position through that spine, they're not advocating that. They're just saying we have more, the light shines brighter, and we have more torque. They're not advocating do this, okay? But you can see where it would be really easy to read the title of this study and read in the key points that, hey, ooh, they're saying that this stuff is getting activated when I round the spine. So that must mean that that's what I have to do.
Correct.
And
Correct.
that's not what they're advocating. So if you don't know how to read through the research, it's difficult. It's this is like a minefield, and I learned the way that you get better at doing this is to read more research and to ask the questions. And I'm glad that Dr. Osar, thank you for sending this article my way. I learned a lot from reading the article. But those are kind of the take-home points, and I like to also highlight we got to learn from the past and other studies as well too. So we hear all the time in the industry, whether it's rehabilitative, corrective exercise, or just regular training, contract the TA. This is the same thing, okay? When we contract the TA, you're looking at one component of an overall greater movement. The brain does not understand and does not work off of isolated contraction. Can it do that stuff in certain cases if you ask it to? Yep, but it's very, very difficult to do. And that's not how it operates. So when we look at the studies involving the TA, we made that same mistake in the past. Hodges did not advocate just saying contract that TA and nothing else. They looked at the diaphragm. They looked at the extensors in the back. They looked at the pelvic floor. They looked at the psoas and how that connects into all of that as well too. They understand we have synergy, we have a movement going on, but somehow throughout the industries, both rehabilitative as well as corrective and performance training, it got miscued and everybody hopped on the train, contract these muscles, and it'll get you where you want. And now it's mainstay in the industry, and we're trying to undo that. And it's very hard to undo when you have high-level individuals that don't understand how to apply things here. So I want to say to you guys on here, kudos. I tip my hat for you being on here and learning this information. Don't make the same mistake here with this. Use the take home and understand what these things can and cannot do for you.
Awesome. Awesome. Fantastic information. So, okay, what are we going to do to apply this information to our clients? Because to your point, Darren, I think a lot of people read the title, and I saw one colleague, let's just say colleague, he's a fellow chiropractor, post this study, and he's like, well, maybe we shouldn't, put people in such specific positions when we squat them. And that's, again, just more looking at the title and reading the abstract and not actually diving into the study itself. So I want you guys are familiar with how we look at the body and how we look at movement, and that's a flexed spine posture. And that's me staying in a flexed spine posture, and that's me also driving myself into extension to better recruit my glutes, right? And we see what happens when that happens. I should say, we know when that happens, what happens when we squat in that position for some of our clients. In fact, right after I did that set, like one set, I felt I did my range of motion before, I did my range of motion after, and I lost range of motion in my hip rotation. And I started to have a little bit of sensation of a little tingling in my left foot. So I did my correctives, got myself reset. And then I redid the exercise with more of a quote unquote neutral spine alignment, more that we would advocate in the integrative movement system and the integrative movement system approach. It's the same weight. I did a few more repetitions this time, just with a more controlled position, TPC, that thoracolpelvic cylinder, better controlled, better eccentric control, less overactivation of the glutes. The glutes are still obviously activating, but just less overactivation, less compromise of my hip position. And then I did my before and after range of motion, and range of motion was good. So again, what Darren and I really want you to take home from this webinar is to really understand and look at the research. Don't just look at the abstract. Don't just look at the title. Look at the number of individuals, the type of study, number one. Number two, the number of individuals that were studied. And number 3, what does the study actually not say? It doesn't say to train people in a flexed spine posture. It just says that, to Darren's point, that there's better neuromuscular efficiency in the flexed spine position for this particular task. So we want to make sure we look more closely. And your take home is always take this with a grain of salt and ask yourself, does this apply to my individual client and my individual population? And for those of you that train one-on-one, obviously it's applying to your individual client. And if those of you training bigger groups, you have to then again apply this information to those groups without knowing specifics about every single one of your clients.
So, Evan, that was awesome. You really nailed it. Can I add one more little thing to that?
Oh, absolutely. Go ahead.
Let's could you go back to that previous slide real quick?
Mm-hmm.
And you guys are I want to point out, you guys are already utilizing some of this if you are following this type of these type of cues and this type of alignment. So if for those of you who are working with somebody that you can't get into an upright squat position, and we need to normalize breathing in that cylinder and everything, where's the starting point? We get them on their back and we put their feet up on a wall in a 90-90, and we can do a lot of different things. That's not the only way to work things. But what does that do? That does not allow the lower spine to get into that excessive position. It recruits those particular muscles that the study looked at, but it's not recruiting the flashlight or the drill at that high level, and it's teaching it to work at the lower level in a position that it needs to be in. So you're already doing some of this if you take the movement and drop them down to a more stabilized position in order for them to be more successful. So just another way of a different lens to look at it.
Absolutely. Awesome. So again, trust your process. Many of you that are on here now, you're already familiar with the integrated movement system. Trust the process. Remember, you assess your client so that you know what they can and can't do, what their limitations are. You address using your corrective exercise strategy, and then you implement it, you integrate it into the fundamental movement patterns, and then you reassess to see what impact you had upon your client. Trust your process. Teach your clients to also have faith and trust the process. So next time, if you guys like this series, we'll find out first, did you guys find this information useful? And would you like to see another episode? If there is another episode, we are going to cover the topic of does scapular stability matter? Because there's a recent study that just came out that said scapular positioning, alignment, and control, dyskinesia, scapular dyskinesia doesn't actually make a difference. And maybe it's a quote unquote a normal variant, and that's maybe what the body should be doing. So we're going to address that if you do indeed like this and you do indeed would like to see another session. So let's stop screen share and let's field any questions that you guys may have. So in the chat box, just write in your questions. The drawings are pretty accurate.
I liked at the end of your squat where you did the thumbs up and say, wow. That was awesome.
Yeah. Mary Trellis, the question was sample size, 26 individuals. There are 13 males, 13 females. And remember, they were healthy, young females and males. So 26 total individuals. Carol, this was very helpful. Awesome. Mary Trellis, people say loved it. Rahul, Dr. Evans, sir, you gave us great information. So thank you, Darren, for that. We want to see more for sure.
Awesome.
Any specific questions that you guys may have had? The comments are not from Mary. Mary's just fielding the questions and sending them over. Healthy means what? Good question, Darren. Healthy means what?
Because healthy are those. Healthy are the specific criteria that we had up on the screen. That was quote unquote healthy. So they didn't have any general medical conditions, and they haven't had any spinal surgeries or any pain. I believe that was last 12 months, right? Full year?
Yes, 1 year. Yep.
Yeah, so that was healthy. That doesn't mean there wasn't any alternative type of efficiency or strategy that their body used, or any kind of other potential dysfunction that was there. We don't know that because they didn't look at that. So that's where it comes down to, again, when we're looking at a randomized control trial, we want to try to control for as many of those things, but you can see where that would get very tricky and very time consuming and hard to do.
Awesome. Yep. Great. Here's another great question. Again, these are all things that I didn't even think of. Can we assume that the individuals that were in this study had previous squatting experience?
Yeah. We don't know that because there was no instruction given. So here's the take home. If it's not written in the study, you have to question it. So there are a lot of times to where, for editing purposes, you do a study. Like, for example, when I did my doctoral dissertation, my study ended up being like over 200 pages, all of it. It was a lot, but you read something, and I think this one was, I don't know, 15 pages or so. It was, it was on the longer side a little bit, but they were pretty thorough. So if you're going to ask those questions, you want to look in writing. And what I typically do to save time, if it's longer, I hit the old Command or Control F, and I find whatever words I'm looking for to go through the study real quick, so I don't have to read the whole thing. And then I can see, is it there? Is it not there? If it's not there, you have to question it. But that doesn't mean that it wasn't done. A lot of times, for brevity purposes, editors will say, you need to take some of this stuff out. So question it, contact the authors if you really want to know.
Got it. Huge. That was an awesome question. And again, just it really illustrates the point that, a lot of people that, and we'll sort of mention the pain science, people that really follow the pain science. And there's a lot of great information and research on pain science. So we're not discounting that information and not saying that we don't use it and apply it in our practices. But a lot of times the people that follow the pain science will start to cherry pick some of this information out and say, see, the posture that you use with your clients does not matter, based upon this brand new study that just came out. And I'm like, that's not what this study says at all. So they're sort of cherry picking their evidence as well. It's almost like, I like to say, it's evidence bias versus evidence based. So you have to sort of look at all the information together, not just a little piece of the information.
Yeah. And for those of you here, thank you for being here, because that's what you are. The longer you stay in the industry, the more you're going to see that. So people get so passionate about what they do that when it comes down to a method or a way of doing things, people hold it as close to their chest as religion and politics, and they get fired up, and they will find anything they can to discount you. I know it because I get it all the time on my end, and they will handpick, they will cherry pick, and my reply to those individuals are kind of how we stripped it down today. Well, you're saying this works. So are you using it in an isometric nature? Are you using it on these individuals? Are you using the measures of how it works using force plates and EMGs in your clinic? You don't know these things, but they do it because they're threatened, and they want to get their point across that we're better than this or that. And it's not. All research is good. All methods are good. It's just how you apply them and the situation in which you're applying them to.
Absolutely. Another question came through, is some of this research, I don't know if this is from Stuart McGill, but similar to Stuart McGill's. And I think to a certain degree, it's very similar to some of the things that Stuart McGill has put out in his research, saying that some of the strongest guys, because he looked at powerlifters specifically, and he did say that they were stronger in the flexed spine posture.
Yeah.
But one thing I'll say about those studies and looking at that population is, remember, it's a very homogeneous audience or crowd or population, I should say. Very homogeneous population, generally on the younger side, generally on the healthier side, generally training for a particular sport and activity where you're judged upon the maximum weight lifted. And when you're looking at maximum weight lifted, the best way to maximally lift weight, any weight, is to shorten the lever arms. So you will want to flex your spine to shorten the lever arms. And then also similar to this study, and Darren, just correct me if I'm saying anything incorrectly, is your best neuromuscular efficiency happen in the flexed spine position. So a powerlifter wants to maximize their neuromuscular efficiency because the amount of time they're lifting a weight is pretty short, maybe that 5 to 10 second range, right? A deadlift is probably happening in five seconds, right? So for them, that information is very applicable. But again, remember the population that you're looking at. Anything you want to add to that?
Yeah, Stuart McGill, great guy. If he were on here with us, he would say you have to look at the whole process. He's not. I'm gonna pick the part that I want to get, but he also knows how to pick things out and apply them, which is what we're advocating here today. Another thing that he gets a lot into is hip socket. How is it actually designed? What's the depth? What can that do for us? He's not I'm gonna pick one muscle, and he's a very systematic kind of guy, which is what I appreciate about how he approaches things. But he's going to be very quick to point out limitations and things as well. He's not just going to say do this, do this, do this. He's going to say, all right, let's look at the situation and let's adapt for that individual's needs.
Absolutely. So here's another question. Somebody asked, can you show me the fully flexed standing posture? And I don't know if the research actually defined what that position looks like and how they figure it out if somebody was fully flexed or fully extended. Can you comment on that?
That is, these individuals were not given instruction. So we have to go back to what was said there. So all of you know that the more flexed we get in that hinged position, we're going to have a certain amount of hinge, and then that's all we got. So then butt's going to start to move back, body's going to start to move forward. We got that counterbalance. We're lengthening out the lever arm, as Dr. Osar is saying here. So what's that going to do? The further we lengthen out the lever arm and come away from that center of gravity, the more torque we produce. And the more torque we produce, the higher the flashlight is going to be on, the brighter it's going to be. Is that what you're trying to get at? Is that what you're going for? Or do you not want to see a person get too far back with too much rounding? It all comes back to what you want. So I'm not going to say anything's good or bad here. It's what's your end game? What's your measure? What's the needs? What is your client or patient? What's important to them, and where do they want to be in order to get to that safe, healthy, active participation level that they're coming to see you about. So
awesome.
Every time you change, you could look at someone and say, all right, I'm coming down. So if I were to take you, Evan, and you come down this far, you're going to have a certain amount of neuromuscular efficiency and activation. The flashlight's going to be shining at a certain brightness, and you come down 10 degrees more, and it's going to be different. 10 degrees more, it's going to be different. It's going to be different.
Correct.
There's no standardizing this is what you guys have to understand. You may be able to handle it better than me. I've had previous back surgery. I ain't going to get very far. So it's all relative.
And I think that's huge, because think about, you with back surgery, your fully flexed position is going to be different than me with no back surgery. Is going to be different from, I was just working with my Pilates instructor yesterday. Her fully flexed position is way different than mine is, right?
Yeah.
And it's going to be way different than our client that's 70 years of age, likely. So remember, no instructions were given to the clients. They were just told to fully flex your spine. It wasn't fully flexed to here, fully flexed to here and stop. It was just like fully flex and then go do the exercise. So it's all relative to that individual. And that's what we have to sort of remember as far as the study goes too.
Yeah. And just one more little bit to add to that is, not only is the movement relative, but we also know from research that internal anatomy is relative as well too. So they could have been dealing with individuals in their 20s, but we know if we go and we look at the literature that a third of these people are going to have a bulging disc. They're going to have degenerative disc disease. They're going to have different degrees of pelvic tilting, whether it be on one side, both sides. Everyone has an efficient stance that they're going to adopt, and you don't think about that, your brain does. It's in control. So that's something also to take into account. Whoever had asked the healthy question, that's quote unquote healthy because these people don't have any symptoms.
Right, exactly. Last question, and then I got to jump on another webinar. Wouldn't clickbait, I think I know who asked this question. Wouldn't clickbait titles to the research articles just encourage them to be torn apart by peers?
Yes and no. There's a lot of trolling online. So it doesn't matter how educated you are and how you're saying things. I try to be careful, and and I'm respectful of everyone's thoughts, and everyone has their own experiences on things, and we all have different levels of training. But yes, absolutely, it drives me nuts. But I'm not going to spend my time in my day when you just go on YouTube and they say, click here. All you have to do are these 3 exercises or this one thing,
Right,
and you see
correct.
that they have thousands and thousands
Right.
of views. Why is that? It's because there's a lack of corrective exercise in medical professionals and just competent professionals that are in the industry. So people are looking for self-help, and they will go to the lengths to do this stuff. So that should tell you the dire need for understanding this material and applying it, which is why I teach to begin with. People need to know.
Yeah, absolutely. Okay, very last question. Very last question.
Okay.
Seems like a very small sample size, 26 individuals, and I would 100% agree. That's a really small sample size, and it's a pretty homogenous sample size. Young, homogenous, young, healthy individuals. What size population do you start to look at and say, hey, you know what, this may be applying across a more broad or general population?
Yes, that's a great question. So numbers are very, very different. The answer is it depends. And people use this as leverage to say, well, they only studied this many people. So what'll happen from a statistical standpoint, when you go and you don't have enough people in your study, you have a very small sample size, there is a certain amount of people, depending on what you're studying with your intervention. So let's say that you want to show that an intervention results in this outcome. Okay. You have your entire population in the world that you have handpicked. I want to do a study on these people. And when you do a randomized control trial, you're taking a small sample of that bigger population to represent the entire population. So you don't know what you're going to get because you're randomly picking these people. So the representation of how well this intervention is going to work and provide the result that you're saying is going to provide really depends on who you have in your study and how it affects them. So ideally, the more numbers you have, the better. But you'll get to a plateau, and you can actually get to a point where it actually goes in another direction. That's a conversation for a different time. But if you don't have enough people, you run the risk of saying that something doesn't work when it actually could potentially work. Okay. So the more people you have, the greater possibility you can show that this intervention can have a good outcome. But in this case, we had a small amount of people, and it showed these certain things. So that tells you the prevalence of what you'd see in the greater population is pretty high. Sometimes you have to study a lot of people to find out how prevalent this actually is. So that's where the numbers come into play. I hope that clarifies things to you. If you find that it makes a mathematical difference statistically, you're on to something there. And generally, you want to repeat with higher numbers.
Awesome. Just got the last comment. Thank you, guys. Love this. Great answers. Thank you, Darren, so much. It was truly, truly eye-opening for me. Had a lot of fun. Our community loved it. So I guess we're going to come back with episode 2 in June.
Yes. Awesome. Awesome. If any of you guys have any additional questions, you're in contact with Dr. Osar. He can forward my information over to you.
Absolutely,
and I'd be happy to continue this conversation via Zoom, via online, with whoever. I love this stuff and just want to educate people. So feel free to hit me up, please.
Awesome. Thank you so much. Have a great day. Happy Saturday. Appreciate you, Darren. We'll see you next time,
All right.
and make it
Thank
a
you.
great day. Thanks, guys.